All right, I think we can get started here. My name is Jamie Kelly. I'm a PA at the University of Vermont Cancer Center and one of the co-chairs of this conference. I work on the inpatient hematology team at UVM, where I have the privilege of helping to care for many awesome people who have unfortunately been diagnosed with leukemia, lymphoma, and myeloma. I also have a special connection with these awesome people, as I was also diagnosed with lymphoma in 2022. This definitely gives me a unique perspective as I carry out my job every day, and I'm really grateful for that. I'm so glad all of you are here today. It is my pleasure to introduce today's target-acquired panel moderator, Dr. Sakshi Jasra. Dr. Jasra is a physician in the Division of Hematology and Oncology at the University of Vermont Medical Center, managing myelodysplastic syndrome, acute leukemias, lymphomas, multiple myeloma, and myeloproliferative neoplasms. I hate saying that word. More importantly, Dr. Jasra's greatest mission is to care for people at a difficult time in their lives, and she feels grateful for this opportunity. She centers her care around treating patients how she would want her own family treated. I love that. Making them feel as comfortable as possible during the visits and forming meaningful relationships with each patient allows her to provide the best care for her patients. To further improve her quality of care, her research interests include exploring mechanisms and clinical relevance of clonal hematopoiesis, barriers to improving oncology clinical trial enrollment in rural populations, and novel treatment approaches for myelodysplastic syndrome and acute leukemias, and the application of cellular therapies in hematologic malignancies. I'm sure you'll all have questions for Dr. Jasra and our stellar panelist. Love learning from Pharmacist. For the Q&A at the end of this session, Zoom attendees, you can chat your questions and a volunteer will read them out loud. And for in-person attendees, there's a microphone right there, and I can also bring you one around. Please join me in welcoming Dr. Jasra and these stellar panelists.
Thank you, Jamie, for that wonderful and kind introduction. I will just introduce our co-panelists today. I'm joined today by Dr. Jacob Barker and Dr. Robert Cade, who are both clinical pharmacists in the Division of Hematology and Oncology. Dr. Barker practices with us in the outpatient clinic and is a really great colleague whom I can rely on to help me figure out treatment doses, figure out patient education materials, and Dr. Robert Cade's practice is focused in the inpatient setting, where he works in collaboration with Jamie Kelly, myself, and other physicians to provide excellent care for our patients. So I'm going to pass it over to them now.
Thank you, everyone. Thank you for that kind introduction. Today, our title of our presentation is Target Acquired, Locking Onto Cancer with T Cells and Toxins. And then looking at some learning objectives, we're going to describe how bispecific T cell engagers, or BiTEs, and antibody-drug conjugates, or ADC therapies, work as specialized precision weapons to fight against cancer. And we're also going to explain some side effects of these treatments, specifically off-target side effects, and then cytokine release syndrome. And then we also have nothing to disclaim as well. And so just before we actually get started, we've talked about these two drug classes. We did want to go over maybe a little bit of the history of cancer-directed therapies. I think as we go through the progression of this history, we kind of see where these, why these treatments were designed the way they were, and it kind of gives you a good perspective of where they've come from. So it's going to be an extremely brief history, but starting in 1949, it's actually we had our first cytotoxic chemotherapy drug for cancer. It was mustargin. It's actually a nitrogen mustard, but based off of a lot of the research they did in World War I with mustard gases. And for the next couple decades, we really started focusing on trying to create new chemotherapy agents, and then working on compounding and creating groups of them to work against cancers and stacking them together to create combination therapies. And then in the 70s, we actually started with our first immune therapy drug against cancer. So we kind of known since the late 1800s that the immune system plays some role in fighting cancer, when we had doctors injecting bacterial toxins into sarcoma tissue and seeing responses in that treatment. And so TICE BCG is a more, significant way of doing that, but attenuating the bacteria to be injected into the cancer. And then the next couple of decades, we worked on finding other ways the immune system could also help us, and antibody therapies became very important in that time frame. And then in 2000, we actually had our first antibody-drug conjugate. I would say these drugs kind of stumbled out of the gate in the beginning. So they were, the first one was a quarter of a century ago, but we really haven't seen too many of these up until now, where we really started fine-tuning their development, and we're seeing more and more of them come through. And then in 2014, we had our first bispecific T-cell engager, and those have really kind of taken the forefront, as we kind of delve into immunotherapy. So again, a very brief overview of traditional chemotherapy. These are just drugs that kill cells that rapidly divide. And so that's what the cancer is always doing. Cancer just continuously grows and grows and grows, and thus these drugs do a great job attacking those cells. But sadly, we have a lot of normal, healthy cells in our body that grow in a quick manner as well, and that's really where a lot of the side effects come from. Outside of nausea, vomiting, hair loss, mouth sores, low blood counts, these are all just due to the fact that those cells are growing while the chemotherapy is in the body, and thus they're going to be targeted by that chemotherapy. Again, we talked about how they were first used in the 40s, but it really wasn't until 1970 when we started using a lot of the combination of these drugs that we saw that they were able to cure our cancer. Again, that's usually due to use of combinations. Just two common regimens just to kind of slowly bring up, or quickly bring up, is CHOP and FOLFOX. Really, when we try to define these regimens, the combination regimens, we have to really focus on not overlapping the mechanism in which these drugs work. We want to attack the cancer through various mechanisms, but we also can't overlap a lot of the toxicities as well. And so they're quite difficult to create these combinations, but also quite difficult for patients to tolerate them. And so not every patient can ideally get chemotherapy regimens that are preferred. And so from there, we really had to start thinking about how can we target treatments? How can we make it so it's not just, I kind of view these chemotherapy drugs as carpet bombs. We're just kind of carpet bombing your body. Any cells growing during that time will be impacted by the chemotherapy. And so to target it, be more targeted, we started utilizing antibodies. And so these are Y-shaped molecules produced by our immune system, and they bind to antigens, which are just small proteins on the outside of bacteria cells, viruses, our own cells as well. And so by binding to them, they can attract our immune system to come over and to clear out, whether it's a bacteria cell or a virus or whatnot. And that really is just, the underpinning of our humoral immune system, our adaptive immune system. The nice thing is that we can target millions and millions and millions of different types of antigens. So really, we can our antibodies will be created to target anything that they can kind of see that are kind of foreign. And another part is that they're also very persistent, and so they can stay in our bloodstream for years and even confer immunity. This is pretty much how vaccines work. We give you antigens, your body recognizes or learns from them and creates antibodies that will then target them if they ever see them again. To give you some just visual representation of that, you see this bacteria cell with these triangles on the outside. Those are the antigens in which you have antibodies will come towards and bind to it, and then your immune system will recognize all those antibodies on the outside of the cell and then clean up that bacteria cell. So what does that mean to cancer treatment? And so scientists now can actually develop artificially these antibodies. And so we really can target any antigen that we want. The limitation is what we discover in terms of good antigens on the outside of tumor cells. So it can be on any protein, any cell. And we actually have been using them since 1986 when we had our first artificial antibody to fight cancer. Formerly, they were made from mice protein, or made in live mice, and thus, very hard to tolerate because your body can recognize that as foreign protein. But now, through genetic engineering, we can make it, with a combination of both mice and human proteins. They're highly purified. They are only going to target one antigen. They're not going to be able to target anything else. So we coined them, monoclonal antibodies. And so any drug you really see with the MAB at the end of it, MAB, is a monoclonal antibody. So like Herceptin or trastuzumab would be one of them. And so where we had chemotherapy being those carpet bombs, antibodies are much more laser guided directed treatments. And so someone much smarter than myself thought to put those two things together, and that's really where antibody-drug conjugates come from, is taking an antibody and combining chemotherapy to it. And so, they're a new class of medication combining that cytotoxic potential of chemotherapy with the targeted impact of antibodies. Currently, right now, we have about 14 approved or pending approval with big concentrations in breast cancer, lymphomas, bladder cancer, and cervical cancers. But most importantly, there's about 210 of these different antibody-drug conjugates in clinical trials right now. So in the future, we could have a lot more of these in treatment. So again, just what it is, it really is just an antibody, that Y-shaped molecule, and then you have chemotherapy attached to it. And so what we really want is a monoclonal antibody. It's again going to target just these proteins on the outside of cancer cells. We really don't want them, we don't want a target that's also on normal healthy cells. We want a linker, which is the thing attaching the chemotherapy to the antibody. We want that to be strong and not to be have the chemotherapy fall off before it finds its target. And then the payload is just a specific chemotherapy that we attach to it. We can use pretty strong chemotherapies due to how targeted this treatment is. Things that we wouldn't really want to just give into the bloodstream itself. And to kind of show you just how it works here, I'm not sure if you can see the mouse or not. If not, you have just the antibody-drug conjugate right here binding to the antigen on the outside of the cell. It's then kind of brought into the cell where it creates this endosome, and then these little Pac-Man-like enzymes are brought in, and they chew up the protein, the antibody, and break it down to its components. And during that process, the chemotherapy is then released from the antibody itself. And then once that chemotherapy is released, it's inside the tumor cell, and then it's going to perform its function and destroy that tumor cell. So it's a really nifty way of providing chemotherapy without having the generalized side effects that we expect with conventional chemotherapy. This is just a list of the current ADCs. I'm not going to read through them, one by one, but it's just to kind of represent here that the naming convention, trastuzumab, all the first words there are your monoclonal antibodies. That's the antibody they're using. They all have their specific target, and then the second word are the actual chemotherapy drugs that are attached to the antibody itself. You can see here there's a big a group for breast cancer, lymphomas, cervical cancers. The most important part is that of these 14, there's 10 different targets we're utilizing and 8 different payloads. So these are very highly customizable drugs. Again, we're only limited by what kind of antigen we can find, and then we're testing out different ways, different chemotherapy drugs to attach to it. As I mentioned in the beginning, the first drug was approved a quarter of a century ago. Again, it kind of stumbled out of the gates. These first ones were pretty hard to tolerate. So there's been a lot of improvements that we've made in antibody-drug conjugates over the years. Again, we're going to be impacting all these different types of components. So that obviously we can change the antibody as we find new antigens that are more specific to cancers. Certain cancers, we can adjust to that, as well as switching from mouse proteins to human proteins where they're much more tolerated. Looking at the linker here, we can adjust that as well. So we started off with very strong linkers where the drug was extremely hard to remove. Now we're exploring, enzyme cleavable linkers and things like that, where we can kind of release the drug a little bit differently. And then obviously we can change the payload, but more importantly is how much do we put on? We can put more than one molecule chemotherapy onto these antibodies. How much is too much? What is not enough? And so there's a lot of research going, looking in there, and as we adjust, through different generations of these antibody-drug conjugates, and those is pretty much what I said. I didn't want to put too much data in here, but I did want to demonstrate the impact that these drugs are having in clinical trials. So this is just looking at progression-free survival, which is just the amount of patients that haven't progressed in their disease. So the line on the top is patients doing better, meaning that they haven't progressed. And so Dato-DXd is one of the new antibody-drug conjugates in breast cancer, and it showed significant improvement over just conventional chemotherapy. We've also combined these drugs, so enfortumab vedotin is an ADC that we can combine with other types of immunotherapy against chemotherapy, and it's shown great results. And then even when we compare older antibody-drug conjugates to some of the newer ones, so trastuzumab deruxtecan is a newer HER2 positive breast cancer treatment, and compared to one of the older ones, trastuzumab and tansine, you can see great improvements here, and that has a lot to do with some of those changes we made in linker design and everything like that. Even though these are very targeted treatments, they do come with toxicities, and the toxicities can arise from pretty much any of the components. They all have a factor into it. Obviously, the cytotoxic chemotherapy is going to play the big role, what's causing the toxicities, but Once it's released, into the cell and it's killed that tumor cell, it can release into the bloodstream and then cause, side effects down the road. So depending on just how toxic that drug is by itself, how long it lasts in the body, if it has a really long half-life, it might be in there for longer. The drug to antibody ratio, so how much drug we're putting on it, can impact that as well. And then looking at the linkers, again, if you have a cleavable linker, there's a potential for it to release the chemotherapy prior to meeting the tumor cell, and that can cause side effects elsewhere. And then depending on how specific our antigens are, if our antigens are present on healthy cells, the antibodies could bind to it and thus cause toxicities where we don't want them. So any part of this antibody-drug conjugate can lead to other side effects. And then it's looking at some future directions of interest and research. One is how much target is required, and this is a very HER2 breast cancer specific topic. Looking at the new drug trastuzumab deruxtecan, which we again showed really good results. We're looking at maybe we don't need to have as much HER2 staining as we thought. So to be HER2 positive, we had to stain the cells, and any dark cells were HER2 positive cells, meaning they have HER2 on the outside of it. And originally, you had to have pretty significant staining to be considered HER2 positive. The other boxes would be considered negative, and a lot of the older HER2 positive or HER2 targeted drugs wouldn't allow you to use those drugs in a HER2 low or ultra low setting. But what we're finding is that trastuzumab deruxtecan actually is showing really positive results in those two groups with very low levels of HER2 expression. Again, this is just kind of looking at the three different settings, whether you're HER2 positive, HER2 low, or HER2 ultra low, and looking at how trastuzumab deruxtecan impacted patients with those different levels. Again, looking at the progression-free survival, this 29 months versus 7.2, that's just what I showed you in the graphical slide a few slides ago. Really great results. But even in HER2 low, you're seeing almost a doubling of progression-free survival. And then even in ultra low, extremely low levels of HER2 expression, you're seeing a 5-month increase in progression-free survival. And that has everything to do with the fact that there's these enzymes in what we call the tumor microenvironment. So where the tumor is around all the cells, there's an environment that's pretty nasty for normal cells to live in, but there's all these enzymes in there that are actually cleaving off the chemotherapy before it binds to the target. So the antibodies are going to that area because of the expression of HER2, and then even before it's binding to the cells, the chemotherapy is being removed, and then once it's removed around the tumor cells, it can attack a HER2 positive cell, it can attack a HER2 negative cell, and so it's actually providing a lot of great results there. And just kind of demonstrates how these new designs and linkers are really improving the effectiveness of ADCs and allowing us to work around the tumor instead of just directly inside of it. Then the last thing to talk about is off-target side effects. And so these are specifically good examples, ocular toxicities or toxicities of the eye. And so these are 4 different antibody-drug conjugates that are approved right now. And you can see right here, all 4 of them have pretty high levels of ocular toxicities. Some even needing to see optometrists or ophthalmologists prior to dosing of these. A lot of eye drops required. And so when trying to figure out what the cause of this was, we're looking at, again, all these different antibodies we're using are targeting different things. So it's not like there's a pattern there. These 2 antibodies right here actually aren't even present on cornea cells where a lot of these side effects are happening. When looking at the linker, we have non-cleavable, cleavable, enzyme-cleavable linkers, so that didn't seem to be one of the causes. And then even looking at all the treatments that we utilize, the different drugs, again, there's no real pattern to be seen. But what we did kind of discover was it was actually due to this process called macropinocytosis. And so when I was taught in biology class, pinocytosis is how a cell drinks in more fluid. And we're actually seeing that it's just actually sucking in all these antibody-drug conjugates, even though they're not bound to any of the antigens on the outside. And so then, once they're inside the cell, they're going to do their job and release the chemotherapy. And that's how we're getting some of these toxicities in places that we wouldn't expect or do we want to happen at all. And so this is actually a really kind of tough thing to manage. It's really hard, burdensome on trying to get ophthalmology appointments and everything. But sadly, a lot of this is just breast cancer ADCs that are in trial right now. And so ocular toxicities are going to be something that we're going to be dealing with for a long time down the road, especially as we're seeing really good results with these drugs. Then just a quick summary here. So antibody-drug conjugates are just, again, combine the destructive power of chemotherapy with the targeted approach of monoclonal antibodies, consistently showing improved results in compared to conventional chemotherapy. Again, there's 210 of these currently being studied, so again, we're going to be seeing a lot more of these in the future. And then there's still a lot more to explore in terms of off-target side effects and then linker design as well. And then at this point, I'll transition it over to Dr. Cade here, and he'll be able to talk a lot about BiTE therapies.
All righty, well, thank you very much. We're going to talk about a different technology here called bispecific T-cell engagers, also known as BiTE therapies. More recently, we've discovered how to design antibodies with arms that bind to different antigens. Usually, like antibodies, both of the arms will bond to a single antigen, but now we've figured out to make it a little bit differently so that one arm will bind one antigen and one arm will bind another antigen. So we've taken that into our advantage. CD3, for example, is a protein expressed on killer T cells. So if we make an antibody with one arm that attacks CD3, we can make one where the other arm can target an antigen of our choice. Maybe, for example, an antigen that's expressed on a surface of a cancer cell. So what will happen is that you get an antibody that will attack one antigen on a T cell, one antigen on a cancer cell. This will cause these cells to come together, and we call these bispecific T cell antigens engagers because it will engage one target on one side, one target on the other side. This pulls the T cell into close proximity of the cancer cell, and the activated T cell will then go a little crazy. It'll see the enemy in close proximity to it, and it will kill it. So here's an example of how it works. Here is the two-headed antibody here, the bispecific T cell engager. It targets a cell surface protein on the cancer cell, whatever one it cares to target, whatever one has been designed to target. The other one will attack CD3 on the surface of the killer T cell. The killer T cell gets activated and it kills the cancer cell in the process. So another way of explaining how it works, a little bit more, a better way of explaining to kids maybe. For example, it's like this guy that has these two dolls and he's forcing his two dolls to kiss. One of them is a cancer cell and one of them is a T cell. And when you kiss a T cell, it's the kiss of death. So let's talk about some of the adjectives. One of the examples of this. Blinatumomab, for example. This one was the first one to establish widespread clinical use back in 2014. It is used for acute lymphocytic leukemia, and it binds to CD19, which is expressed on the surface of acute lymphocytic leukemia cells. The other arm binds CD3, again, which is on the surface of killer T cells. It pulls the killer T cell into close proximity to the ALL cell, activates the T cell, and the T cell will kill it. So it's used in, we have a couple of different times when we use blinatumomab. For example, if we've already treated the ALL and the patient is in remission, well, there might be just a little bit left over that you can't necessarily see, so we add blinatumomab at this point to eliminate whatever microscopic disease is left over that we can't see. Similarly, if they are in remission but they have minimal residual disease, that is, we can count one cell in 1,000 cells as still leukemic, which means they're so close to being in remission but they're not quite there, we can give blinatumomab and that'll take care of the rest of the way. We can also use it in patients whose disease is resistant to treatment. For example, we just started chemotherapy and we tested them at the end of chemotherapy and, your disease is still there. We can give blinatumomab as a second choice, and it works pretty well in those cases. It tends to be a little bit more toxic, though, unfortunately. And we can also use it in patients who get cured of their ALL. They stay cured for a couple of months, but then their disease comes back. We can use it for second-line therapy also. All the clinical trials for them shows that blinatumomab works really, really well. But it's given with a lot of difficulty. It's given around the clock for 28 days, which basically means you have to put them in a pump, like a little fanny pack with a little bag of drug in it, and it has a pump that the patient wears, and they go about their day-to-day life. They go to work, they go to church, they go for a hike in the mountains with this thing that they're wearing that pumps the drug into their body slowly over 28 days. And then they come in to us and get the bag exchanged every week, and then they go about their business. Once that 28 days is over, then they can be free of the bag for 14 days before it's time for the next cycle, and then we bring them back in and put it on. The first few days of treatment after the diagnosis, and we decide to proceed with this, we typically will admit them to the hospital because of the side effects that are associated with this. The worst of them happen in the first couple of days, and I'm going to talk about what those side effects are here in a little bit later, but it frequently involves coming to the hospital for a few days, us watching them, and dealing with it as it arises. All right, next drug I'm going to talk about is epcoritamab. This one is used for diffuse large B-cell lymphomas and other kinds of aggressive B-cell lymphomas. Recently, it was also approved for follicular lymphoma a couple of months ago, and it targets CD20 on the surface of B-cell lymphoma cells. It will pull in a killer T cell by its CD3, activate it, and the killer T cell will kill that lymphoma cell. This is done in patients who have tried 2 or more lines of treatment already, and they haven't seen the results that they wanted from it. So we can try epcoritamab in that case. It can also be used in patients whose disease comes back after these 2 lines of therapy have already been given. Well, it's time to give chemotherapy a break, and we're going to try this bispecific T-cell engager instead. This one is different. It's not given as a 28-day continuous infusion into the vein. Instead, we give it as a shot under the skin. It's given once weekly for the first 12 weeks, and then once a month after that, assuming that the patient has responded well to it. And the first 2 doses are step-up doses, which means first dose is a real tiny little amount, and then the second dose is a little bit more, and then the third dose, that's the first full dose. And the first full dose, we bring you into the hospital for the side effects that I'm about to describe. We have to keep a close eye on them, and if they have these side effects, then we're in a good place to respond to them. Teclistamab. This one is used for multiple myeloma cells, and it targets the B-cell maturation antigen, which is expressed on the surface of multiple myeloma cells. Again, we are looking at the other arm going after CD3 on killer T cells. The killer T cell will activate, kill the multiple myeloma cell that it's hugging right there. This one we use a little bit later in patients who have multiple myeloma. It's patients who have gotten 4 lines of therapy or more, and that they've been resistant, or the patient who's gotten 4 lines of therapy and the disease has responded but then has come back. There's more and more clinical trials looking at teclistamab a little bit earlier in the treatment of multiple myeloma, so chances are eventually we're not going to have to wait until 4 more lines of therapy have gone by to get this. This might be an earlier line of therapy. This one is also given as a shot under the skin rather than as IV like blinatumomab is. This also starts from a lower dose. We give a low dose on day 1. We give a little bit of a higher dose on day 3, and if everything's going well, nobody's having any side effects, then we give the first full dose on day 5. And then after that, we give it once a week, and the once weekly dosing happens quite frequently for the first several months, but the first couple of doses, that step-up dosing and the first full dose, we need to admit you to the hospital to watch out for the side effects. We actually have a couple of patients on our list to be admitted to the hospital in the next couple of weeks for this therapy. Now, there are a couple of other bispecific T cells, for example, that target CD20. Mosunetuzumab is kind of like the one that I just described. Glofitamab, all of these target follicular lymphomas, diffuse large B-cell lymphomas. The dose is a little bit different. The clinical circumstances are a little bit different than what we use epcoritamab for. The dosing's a little bit different. There's also talquetamab that targets a different antigen on multiple myeloma cells, specifically GPRC5D. We often use this after teclistamab, and it's got a different side effect. It makes the patients lose their sense of taste, which is kind of annoying sometimes. Oops. We also use tarlatamab, and this one is for a solid tumor. This is the first bispecific T-cell engager that has been approved for a solid tumor, specifically small cell lung cancer therapy that's progressed after first-line therapy that contains platinum. One thing that all of these have in common is that they all have step-up dosing, and it also requires at least 1 dose to be given in the hospital so we can keep an eye on the side effects and we can treat them if they happen, and I'll talk about those in just a second. There are a lot of clinical trials underway looking at new bispecific T-cell engagers that will eventually enter clinical use if it turns out to be positive. For example, MCLA 117, which targets CD3 on the surface of T cells on one side, and CALC12A on the other side, which is expressed in acute myeloid leukemia cells and also myelodysplastic syndrome. That clinical trial is underway. Also looking at KM257, which targets HER2, which is expressed by some breast cancers. We're looking at that in clinical trials. RCC3 is looking at CD276. It's under clinical trials in colon cancer and rectal cancer. And lastly, BRIGHT, which is targeting EGFR-V3, which is expressed in glioma, which is a specific kind of aggressive brain cancer. These have not yet been approved by the FDA, but if it works, then there's a pretty good chance that we're going to be seeing these in the next couple of months and years. There'll probably be similar side effects because they all kind of work similarly. Many of them will probably require admission to the hospital for the first couple of doses. Okay, now, as promised, I said that I would go over the side effects with you. There's two big ones in these. CRS, cytokine release syndrome, and also neurologic symptoms. Immune cell-associated neurotoxicity syndrome, which we often call ICANS. So keep those in mind as I talk about these. Cytokine release syndrome, or CRS, basically it happens because the drug does its job too well. Bispecific T-cell engagers work by activating T cells in the presence of cancer cells, and depending on how many cancer cells there are, the more cancer cells they are, the more active the T cells become, the more active the immune system becomes, and as a result, it can go a little haywire with these first couple of doses. So the T cells release their cytotoxic molecules that kill the cancer cells, but in the process, they also release a whole bunch of signaling molecules that activate other aspects of the immune system, and you get a volume cranked up on the immune system as a whole. So the things that we watch out for specifically include fever, which can be high and prolonged. We look at low blood pressure. The immune system thinks that the body is being invaded by an infection, basically. So the blood vessels become leaky to allow the white blood cells to go around the body, seek out the infection if there is one, and go after it. So as a result, because of the leakiness, a lot of fluid leaves the bloodstream also. This causes the blood pressure to go down. The heart rate has to increase to compensate, so you end up with a faster heart rate as a result. In worst cases, you get low levels of oxygenation in the blood. And in the worst cases, the very worst cases, you can get multi-organ failures, particularly the kidneys and the liver, which seems to be the worst, the first to be engaged in this. This is very similar to what happens in really bad, severe infections. For example, like COVID, where the immune system can have a runaway activation. We call this sepsis, related to infections. Cytokine release syndrome that I'm talking about is very similar to sepsis. It can be kind of difficult to tell the difference because it's also an immune runaway reaction. The only difference is that in cytokine release syndrome, there's no infection. It's not caused by the infection. It's caused by the drug reacting to the cancer and overactivating the immune system. This typically happens within 48 hours receiving one of the step-up doses or the first full treatment dose. It can occur later in therapy, but that tends to be less common. For example, if it doesn't happen after the first full treatment dose and it hasn't happened during the step-up doses, it's not going to happen at all. And you can worry about this a little bit less, which is why it's important to watch out for it very closely the first couple of doses, maybe admit patients for observation, but after that, they can get all their doses as an outpatient. Now, to try to tip the odds in favor of the patient, we tried a couple of different strategies. For example, I mentioned the step-up dosing a little bit earlier. We start with a low dose, then a few days later, if there's no CRS symptoms, no fever or anything else, a few days later, if everything looks good, we give a higher step-up dose. Then a few days later, we give the first full dose. And if there's any idea that if CRS is going to happen, it's going to be milder if there's less drug around to stimulate things, which is why we start with a low dose and then work our way up. We also pre-medicate each dose with Benadryl, Tylenol, dexamethasone, try to keep a damper of things. We watch the patients very carefully during the time when the risk for CRS is highest. In fact, we're required to admit them to the hospital to receive some of the step-up doses and for a definite period elsewhere. This varies by drug. Some of them say 16 hours in the hospital. Some of them say 2 days in the hospital. If CRS happens anyway, then we have a couple of options to how to address them. If it's mild, we watch them very carefully, give them fluids, give them Tylenol, just kind of help them try to feel comfortable. If they're not getting better, like it's a fever that isn't improving, or their blood pressure is going down and it's not getting better, then it can be a little bit more aggressive. We can give steroids like dexamethasone to kind of put a damper on the immune system. We can give a drug called tocilizumab, which blocks a specific immune signal molecule called IL-6. We actually figured out how to use that during the COVID pandemic. We figured out that if patients are really, really sick because of COVID, tocilizumab works to kind of tune down the immune system. Same thing happens here. It's tuning down the immune system. If blood pressure is dangerously low, we can move them to the ICU and give them drugs to make the heart beat stronger. These are called pressors, and that will increase their blood pressure to safe levels to make sure that their brain, their other organs are adequately perfused by the bloodstream. Now, on the other hand, besides CRS, there's also neurological symptoms. And these are caused when the barrier between the bloodstream and the brain tissue breaks down in the setting of immune system overall activation. And this happens later than CRS. CRS usually happens within a couple of hours to a day or two after starting therapy. This can happen up to 5 days later, and sometimes it can show up even a couple of weeks later. That's less common though. The early symptoms that we watch for include things like the shakes, tremor. Patients can have difficulty speaking, like it slows down as if they have to think more about what they're saying and the order of words that they're putting them in. Their handwriting tends to get a little sloppy, a little bigger. The letters become less distinct. Disorientation to place. You ask them where they are and they say, I'm in the airplane, or I'm at the market. They don't say, I'm in the hospital, for example, or they don't, wherever they are, they're not able to identify where they are. You ask them to name things in their environment, like, point to this, what is this? They can't say that's a pitcher, or those are a row of glasses or something. They come up with a name of something that is not there, then that's a sign that they could be having this neurological symptom. More later, after a couple of days of this, if it's not improving, then you can see a little bit more worse symptoms as well. So agitation, they start thrashing around. They don't feel comfortable no matter what they do. They lose the ability to write. It's not just like bad handwriting. It's that they just kind of, you ask them to write something and they end up just putting a line on the page. Lost ability to speak. They become completely aphasic. Seizures is really bad, and when that happens, you got to do something about that because that means that the patient's going bad. It can cause brain swelling and eventually coma and death, but fortunately those are less common. We still have to keep an eye out for that in case things are going bad. We can assess neurological symptoms with something called the ICE score tool. We ask them, okay, where are you? What year is it? What month is it? What hospital are you in? And if they can answer all these questions correctly, then they get points. Point to a couple of things in their room. Say, what is that? Point to their window. If they say window, then they get points for that. Pen, button, anything else in their room. Ask them to do things like show me 2 fingers or close your eyes and stick out your tongue. And if they do this, then they get points for that. Writing. We typically ask them to write a sentence of their choice on the first day of therapy and come by every nursing shift and ask them to write that sentence again on the same piece of paper and look for changes. If they start having to think about what they're doing, or they can't really write it, or you can't really read it because their handwriting has changed too much, well, then they were going to lose points from that. And also ask them to do a task that requires them to think, like count backwards from 100 to 0 by tens. 100, 90, 80, 70, 60, et cetera, et cetera. If they lose the ability to do that while you're seeing them, that could indicate that this is about to happen. Okay, so neurological symptoms are caused when this barrier between the bloodstream and the brain tissue breaks down the system of immune system activation, and it happens in some cases. You kind of know when it's going to happen, when it's likely to happen. If they've already had the cytokine release syndrome that I mentioned earlier, that's a risk factor. Older people are more prone to it. People with worse cancer, if there's more of a tumor burden, there's more of a chance for the immune system to get activated. They tend to be more prone to it. The treatment for this, supportive care, we usually admit them to the hospital for this to keep a close eye on them. We can give them seizure medications in case their seizure seems to be more prone to seizures than anything else. steroids to damp down the immune system, dexamethasone. We can also give other immune suppressants such as anakinra, which can actually get into the brain and shut down the immune system active cells that are there. All right, so in conclusion, the the drug classes that we've talked to you today include antibody-drug conjugates, where antibodies are used to drag a drug to a specific site of action so that the drug doesn't poison all the cells, but it poisons specific cancer cells that are marked by molecules on the exterior that the antibodies can meet and match. So provides superiority in terms of efficacy over conventional chemotherapy, fewer side effects. BiTEs, on the other hand, bispecific T-cell engagers, introduce killer T-cells to tumor cells, and this causes the kiss of death to help fight the cancer. And the big side effects of these include cytokine release syndrome, which looks like sepsis, and neurological toxicities. So, both have revolutionized the disease states that we've approved them for. They've really come into their own in the last 5 years or so. We've been seeing more and more of these underway, and we're going to see more and more of these as the fight against cancer continues to evolve. They don't carry the generalized side effects associated with conventional chemotherapy. One of the things that you haven't heard us talk about is nausea. It doesn't really cause nausea. It doesn't really cause hair loss. The things that you typically think about when you see like cancer patients on movies or TV shows or something, this doesn't cause any of those stereotypical side effects. Instead, it causes other side effects. ADC can be internalized without binding to cells with this micropinocytosis process that Jake described, causing ocular toxicities and other off-target toxicities. BiTEs can cause the cytokine release syndrome and immune neurological symptoms caused by a runaway immune system. So thank you for coming and listening to us today. We hope that this has given you some information about the directions that we're going with cancer now and in the future. And with that, we are happy to take any questions that may arise.
Thank you very much. I just have a question about the second presentation, excuse me, and the BiTEs. What are the likelihood of permanent damage or permanent side effects and any kind of irreversible damage? Can you speak to that?
Sure,
please?
absolutely. That's a good question. Most of the time, cytokine release syndrome, while it is present and it can be severe when it happens, as long as we catch it and we treat it, it can take a little while to reverse, but it's usually not permanent. ICANS, on the other hand, that can take a little bit more time to reverse. It can extend a patient's admission by even several weeks, but they generally tend to be reversible as well. There can be some like lasting side effects like tremor or something like that. One of the drugs that I was talking about, the one that causes loss of taste, there are some cases that, that's talquetamab, there are some cases where the patient's sense of taste is never regained, basically, and they go through the rest of their life with a diminished sense of taste. It can also cause a diminished sense of smell, which can be permanent as well. And that can actually be really difficult because it's hard to encourage them to eat if they can't taste anything, if they can't smell anything. And that tends to make the treatment of their disease more complicated that way. There's also later on risk of getting infections with all of these drugs that we've discussed. That tends to happen after a month or two of therapy is when the risk is highest. And depending on how bad it is, patients may not be able to recover from those. So, good question though.
I would just add that with regards to the CRS and ICANS, we have really well-used, well-studied algorithms that we'll use to predict which patients may be at risk of CRS and ICANS, and we have a very low threshold for starting either tocilizumab, anakinra, or steroids to try and circumvent it and prevent the patient from deteriorating. And I think in clinical practice, we've been really successful with the use of those algorithms. I think the infection risk is real, but I would also say that we have contingencies in place to start people on antimicrobials to reduce that risk, especially in the era of COVID. We're also very liberal with the use of IVIG, which is intravenous immunoglobulins. A lot of these patients, I think, if we are worried, would be at higher risk, especially during the flu season. We'll talk to them about preemptively starting IVIG to prevent them from getting infections. So I think, yes, there are a lot of side effects that we need to be able to talk about, but we have a really good infrastructure in place to try and circumvent a lot of those issues.
Hi, those were great talks. Thanks very much. I think I had one question, but I think you just answered it, so I'll pivot to another question I just developed while listening. So the ocular side effects that Jake, you talked about, is that due to effect on the, specifically like the retinal nerve, or is that pigment epithelium, or is it a combination of both? Because that's a really interesting, very cell-specific effect. Can you
Yeah,
speak
so
to
it's
that?
actually the cornea cells that are the ones taking it up. So you can actually see, I'm not an ophthalmologist or anything like that, but you can see it starts peripherally, and then you can see it kind of clouds up towards the medial part of the cornea. And so it's just, yeah, very cell-specific. It's not impacting the nerve by any means or anything like that. But yeah, it's just any of those cells that, can take up through the macropinocytosis can cause those, side effects. So we're not quite sure, anywhere else in the body that might also be doing that. But the ocular toxicities are obviously the most apparent to patients.
Thank you.
Hi, you mentioned one treatment for solid tumors, or a couple, I guess, but RCC3 for one, as an example for colorectal cancers. I'm wondering if you could say just a word or two more about that, and if there are any other, treatments, and I've been very much wondering about, CAR T treatment and NK, and where are those at in terms of addressing solid tumors? That might not be quick, I don't know.
I will say that there are some currently underway in bispecific T-cell engagers, and I know that there are clinical trials looking at CAR T-cell therapies for colorectal cancer. It looks like it's still quite a fair distance off. It's more difficult to target those. It seems like it's more difficult to target solid tumors with antibodies that way, because a lot of them, the cell masses can sort of like be hidden away from the bloodstream, and so it's difficult to penetrate deep into those the cell masses, compared to treating blood cancers, which are, every cell in blood cancer gets exposed to the bloodstream. It's a little bit easier to expose them to drugs that you inject into the bloodstream. So I'm hoping that we have some more success shortly, but it's still a couple of years off. Jake, did you want to address the ADC part of
I
it?
think the same thing. I mean, we're always looking for new targets, and as they come, and there's going to be tons. Of the 210 different antibody-drug conjugates, a lot of them are very early in stages of development. So it could be many years before we see them come to fruition clinically.
I would also add that I think for CAR T in either heme malignancies or solid tumors, I think the question is always trying to find the neoantigen that is specific to that cancer. So really trying to limit any off-target effect, I think, is key. I think where precision oncology is headed, and it would be really exciting to do work on, is to try and figure out if there are personalized antigens in each patient that we can then use to sort of design almost like a customized CAR T or a customized clinical cancer vaccine. But I think that that's ways away for now. And I think we have time for maybe one more question.
We have one online.
Okay, perfect.
That's for it.
Actually, maybe we'll do one online, and I think we have one in person as well.
The comment that came in is, having worked in both the inpatient and outpatient oncology settings, I understand the scarcity of resources such as bed availability, staffing, etc. This presentation described that many of these newer therapies require inpatient hospitalization for monitoring of the serious symptoms and side effects. I can imagine this could be a barrier to care. Any thoughts on how this possible increase in hospitalization will be managed?
I feel like this question is directed to me since I'm also the inpatient medical director, so thank you. No, that is a really important question, and it's something that I grapple with on a weekly basis. At the end of the day, we want to be able to deliver this chemotherapy and other drugs in a safe manner for our patients. So patients first. We have a lot of work that we're doing to try and figure out how to decrease the time from when the patient is admitted to actually getting the treatment started, to try and reduce their length of stay and really just try and optimize efficiency in delivery of the drugs. So yes, that is something that we grapple with, but at the end of the day, we have to put patient safety first. And I think we have one more question.
Hi. So you guys described that many of these medications are either used in treatment-resistant or as fourth-line, third-line therapies. Any thoughts on whether or not that may change in the future to move them up the line? And if not, why not?
Yeah, I think that's going to be the direction that a lot of these go. We've typically, when we develop new drugs, they typically get first introduced into patients who don't have any other options. Late line therapies such as, second line, third line, fourth line, where there is no standard of care. For ethical reasons, you don't want to necessarily put somebody on a therapy that you don't know how it works if it's an early line therapy. And then once we show that it works in these disease states, well, then we're going to start seeing clinical trials looking at combining this with chemotherapy in earlier line trials. So it may very well be that in 4 or 5 years, we might see teclistamab plus Cyborg as first line therapy for multiple myeloma, just as an example. I do think that we're going to start seeing these earlier and earlier and earlier.
We do also actually have a clinical trial that's currently enrolling at UVM Medical Center using glofitamab in combination with polatuzumab and a chemotherapy backbone for untreated diffuse large B-cell lymphoma. So, we are trying to look at the incorporation of a lot of these drugs frontline. So I think that's a really good point.
Let's give these awesome people a round of applause. Love the Top Gun vibe. That was awesome. And as you can see, pharmacists are such an important part of our care team at the hospital. We would be lost without them. So thank you so much for all the information. All right, guys, if you are going to Pushing Boundaries, Innovations in Lung Cancer Detection and Treatment, you'll stay here. It starts at 11:10. And then if you're doing Trial Run Inside the World of Cancer Clinical Trials, you'll go over to the Silver Maple Ballroom. And please go get more coffee. We love coffee.